Dr. Radhika. So, for our next panel discussion, I'll call upon Dr. Alisha Chaubal. She is a consultant hepatologist at Nanavati Hospital. She is going to discuss on acute-on-chronic liver failure and the case scenario being alcohol-related acute-on-chronic liver failure, acute alcoholic hepatitis, and ACLF patients. For that panel discussion, I call upon our next panelist, Dr. Rahul Agrawal, gastroenterologist at Surat. Dr. Wasim Khoth, infectious disease specialist at Nanavati Hospital. Dr. Gaurav Chaubal, he is our liver transplant surgeon, director of liver transplant at Nanavati Hospital. And Dr. Saumin Shah, you have to join on that side now. Yeah, thank you.
So good afternoon, everybody. I'm Dr. Alisha Chaubal. We've finished a very thorough discussion on acute liver failure. Now we'll be talking on acute-on-chronic liver failure. Means there's a patient who is already having a chronic underlying liver disease like liver cirrhosis or a fibrotic liver, and he has suddenly decompensated. Means there is some acute liver failure. So normally you see this patient as a prototype, the patient has jaundice and then comes with ascites and encephalopathy. So why is it very important to know ACLF, that is acute-on-chronic liver failure, and how it is different from decompensated cirrhosis, where the patient does not have a very fulminant course, is what we have to see through this panel discussion. So coming to the case, we have a 47-year-old male who had alcohol-induced cirrhosis. He presented to us with confusion which was worsening over 24 hours, and he was having increasing ascites and a dark colored urine. So the patient had been abstinent from alcohol from the past 2 years, but on carefully taking history, the friend finally revealed that he had a binge of alcohol due to depression in the recent 1 month. So this is very important in this case, because a recent history of alcohol within 2 months is important to diagnose a case of alcohol hepatitis. So if somebody has taken alcohol say 1 year back, it is less likely that the decompensation is because of alcohol. The alcohol needs to have been used in the last 2 months. So coming to the vitals, the patient was in hypotension, had tachycardia. Physically, the patient had jaundice, had flaps, which showed that he had encephalopathy, and he had ascites. He was drowsy, confused, a very common scenario which is seen in a lot of emergency departments. When you come to the blood work, he was having a bilirubin of 14, AST of 450, ALT of 220, which is again suggestive of alcoholic hepatitis. His albumin levels were low, INR was 2.8. Importantly, his creatinine was 3.2, and he was having lactates of 6. So I'd like to ask my first question to Dr. Saumin Shah. This patient is having jaundice, ascites, acute kidney injury, hepatic encephalopathy. So what is acute-on-chronic liver failure?
As you already said, that the acute-on-chronic liver failure means already some pre-existing liver disease, either previously known or unknown to the patient, and superimposed by some acute insult. Then time frame that jaundice and coagulopathy worsened by the encephalopathy, ascites, or kidney injury within 4-week time frame. So that is the apostle definition. So that is a simple acute-on-chronic liver failure. How it differentiates from the gradual decompensation from CLD is it is a more having a systemic inflammatory response. So mortality is comparatively very high because organ failure rate and number of organ failure is more compared to the gradual decompensation of cirrhosis.
Right. Yeah. So as very aptly described, organ failure is a very important part of encephalopathy. So this is the Cliff Sofa way of classifying organ failures, wherein the liver is classified to have failed if the bilirubin is more than 12, Kidney, if the creat is more than 2. If the patient is drowsy, that is grade 3, grade 4 HE, then it is considered as cerebral failure. INR of more than 2.5, any use of vasopressors, or he is having respiratory distress with the ratio less than 200. The other thing to do is to classify which stage of ACLF the patient is at, because that is again important in prognosticating the patient. So kidney and encephalopathy are the two most important parts of acute-on-chronic liver failure. So somebody who has isolated kidney failure or isolated cerebral failure is a very risky candidate or is bound to not have a very good prognosis. So if somebody has more than 2 organ failures, it's ACLF2. And if somebody has 3 organ failures, then it is ACLF3. Now, why it is important is that you should note the mortality. So, if it is ACLF1, 20% of them die without a transplant at 1 month. ACLF2, 32% of them die if they don't get a transplant at 1 month. And ACLF3, almost 78% of them die if they don't get a transplant. So the thing to note is the emergency or the timing of transplant in ACLF, because they are such sick patients, we need to stabilize them quickly and bridge them to a transplant. Without transplant, the mortality is very high in all the 3 grades, more so in ACLF2 and ACLF3. So this patient, I'd like to ask Dr. Gaurav. So this patient is having alcoholic hepatitis, more likely. But what are other factors which can suddenly precipitate a patient who is normally having liver cirrhosis to go into fulminant liver failure? What are the precipitating factors that one should look out for in patients with ACLF?
So there are 4 most common factors, and the commonest is infection. So infection is the commonest precipitant. Not the second most important factor is a GI bleed that can cause sudden worsening of the liver functions. Third is any drugs. Most commonly in our cohort of patients, it is the CAMs, community and alternative forms of medicine, which the patient commonly takes when the jaundice is not improving, and that causes a catastrophe. And fourth is like any hepatotropic virus, commonly is hepatitis A, B. So it is a very important practice to vaccinate all your chronic liver disease patients against Hep A, Hep B to reduce the precipitation of acute and chronic liver failure.
Right. So if a patient presents with ACLF, we should do a thorough etiological workup, because treating the etiology also can cause reduction of the liver failure state. Infections should be thoroughly screened for, as they are the most common precipitants, followed by alcohol and viruses. So I'd like to ask Dr. Rahul Agrawal that the patient has come to ER with septic shock. How will you resuscitate this patient?
Okay, so any patient coming with the distress or higher grade of NCAF, we have to resuscitate them. The standard protocol as ABC, as we all know. So for airway and breathing, any patient with grade 3 or grade 4 NCAF, immediately intubate them, because there are very high chance of aspiration. Correct. Any patient having a massive aspiration or ARDS, immediately intubate them. In such a patient, we cannot use a BiPAP like a non-invasive ventilation because of high risk of aspiration. So first secure airway, then regarding shock, the patient mentioned already was in shock, BP was 75/50. So regarding circulation, we have to assess whether the shock is hypovolemic shock, septic shock, cardiogenic shock. There is one misnomer that every cirrhotic patient, we think it's a fluid overloaded. But because of heavy alcoholism, nutritional deficit, they are hypovolemic. So check IVC, get immediately echo done. If hypovolemic, start plasma expander like albumin and IV fluid. In some patient of alcoholic patient, like they may have a cardiomyopathy. So see properly their ejection fraction, RV volume, and start inotropes if there is a low EF and fluid is adequate. Apart from that, 50% patient we may consider as a sepsis because they are already immunocompromised. So start antibiotic as per the hospital policy, whether it's a first or a repeated multiple admissions. So we choose antibiotic as per the previous history. So as per the different etiologies of the shock, we have to manage the patient, like hypovolemic, cardiogenic or septic shock. So stabilize circulation at immediately. Within 24 hours, that is most important thing.
Any preference of the IV fluid you'll use to resuscitate a cirrhotic patient?
Yeah, preferably albumin, means apart from normal saline. If patient is having pedal edema, low albumin level, renal dysfunction, then albumin is preferable.
Right. So preference between 5% and 20% albumin?
20%.
20%.
Yeah.
Okay. And any colloids to be used, normal saline or balanced salt solutions,
Yeah, we
plasma
can use
light?
normal saline. For albumin, as per the guidelines, 1 gram per kg, that is difficult to use in Indian scenario because of economic aspects. So preferably albumin along with the fluid as per the fluid status.
Right. So now we have started using 5% albumin also in patients who are severely dehydrated. We use 5% albumin or 20% albumin along with plasma light to resuscitate them. Monitoring with a POCUS and seeing the IVC is very important, as well as monitoring the lactates. A reducing lactate trend shows that they are well hydrated. So I'd like to ask Dr. Somin Shah, this patient had a raised creatinine. What will you consider a raised creatinine in a cirrhotic patient?
You see, in cirrhotic patient, when you have a ACLF and you have an acute insult, okay, first patient has a previous, if already on diuresis, is it dehydrated or not? If it is a dehydrated or IVC is collapsing, first of all, you have to correct that component. Then avoid any nephrotoxic drug. And use of albumin. I think that is use of albumin, you just start the albumin. And as we have already discussed in previous sessions, if it is indicated, you can go for CRRT also. Only thing what I genuinely means what I feel that the difference in kidney injury or any organ failure in ACLF compared to the decompensated cirrhosis, that you have to remain more aggressive compared to the gradual decompensation, because this ACLF will not give us a time to work up for transplant or patient may suddenly deteriorate. Yeah, decompensated cirrhosis, if patient is developing HRS or what we call the type 2 HRS previously, gradual creatine rising, we have some 1 or 2 months to work up and go for it. So only means if cirrhosis, use judicious use of albumin, avoid any nephrotoxic drug, try to treat shock as much as possible, and avoid any nephrotoxic drug, and CRRT whenever is required.
So acute kidney injury in cirrhotics, you should keep a very, identifying. Somebody who has a creatinine of 0.8 on one day and it becomes 1.1 on the next day, it should not be ignored because that is classified as acute kidney injury. So if the serum creat increases by 0.3 in less than 48 hours, or 50% increase in the creat from baseline, that is within the acute kidney injury, and it should be promptly managed as such. For ruling, for the diagnosis of HRS, the patient should be having ascites, and you should rule out other causes of renal injury through the urine analysis. As sir rightly said, our first thing would be to go through the drug list. We should stop any diuretics which are being given, any beta blockers which are to be given, and also ask for any nephrotoxic drugs which have been taken. We treat with albumin and terlipressin. However, the important part to note in patients with acute-on-chronic liver failure is that they don't tolerate terlipressin very well. So before giving terlipressin, we need to do a baseline ECG. Also ask for history of any ischemic heart disease in the past. So in these patients, terlipressin is a strict no-no. If the patient's age is more than 70 years, if the patient is having ACLF3, that is he's in hypotension, you'd rather prefer giving NORAD vasopressin. If the patient is having hypoxia, he's breathless, please don't use terlipressin. Even patients who have creatinine more than 5, it has been seen that terlipressin is not very beneficial. So any protocol by which you give terlipressin, like do you prefer giving boluses versus a continuous infusion?
We used to go with the single bolus followed by infusion only.
Yes. So over the years, continuous infusion of terlipressin has been found to be more better tolerated by the patient. 2 milligram dose of terlipressin over 24 hours is what we start with and increase if required. We keep a very low threshold for CRRT, that is the continuous renal replacement therapy. So within 6 to 8 hours with resuscitation, if we are not able to achieve a good urine output, and if the lactates are showing an increasing trend, we tend to switch to CRRT in our patients. We don't use SLED by protocol because it is not very hemodynamically well tolerated in this set of patients since their blood pressures are always labile.
I just for your previous slide regarding the mortality, all this insult, either sepsis or superimposed infection, hepatotropic or non-hepatotropic, alcohol or GI bleed, having the same mortality or GI bleed has a relatively less mortality, because
So-
that is the factor which is reversible in ACLF. And in that time, kidney injury may be due to the what we call the volume loss rather than the SIRS. So I don't know, I'm just asking, if patient with the GI bleed with ACLF, even ACLF score 3 on the day 1, we maybe wait for another 2-3 days to decide about the severity or no. You stamp it and go for urgent workup.
No, so obviously correcting the precipitating factors should be done at day 0. Day 4 is when we start assessing them for eligibility of transplant. If we have corrected the GI bleed and the parameters have all come under control, we keep a watchful lookout so that we would not rush into advising a transplant for that group of patients.
But what is your experience? GI bleed induced ACLF has a slightly favorable prognosis compared to the other ACLF? Because even what I feel, okay, when we go for the liver transplant criteria, there is nothing like a portal pressure measurement or a GI bleed is an what we call the liver transplant criteria. It is always, please.
So actually, there is a large study, the precipitant study for ACLFs, in which they have studied the different etiologies which cause ACLF. And it has been found that the mortality with GI bleed as a precipitating event is less compared to infections. So that correlates with your experience also.
Okay. So as I discussed, infection is one of the most common precipitating factor for ACLF. I would like to ask Dr. Wasim Khot to discuss how he goes about screening for infections in patients who come with ACLF.
So for ACLF patient, infection is the most important precipitant also, and also an important consequence. So it is important to be screen for infections, and screening doesn't mean only investigations. It begins with your history taking. We have to diagnose because it is very difficult to differentiate between a SIRS, non-infective SIRS because of liver failure versus proven infection. So right from the history taking, whether we have to identify the syndrome that the patient is having, which is a pneumonia, it is an SBP, or GI infections, or undifferentiated sepsis. That is important based on history. The exposures from the history is also important. And then we come to the investigations part, where imaging is also important to identify the site of infection, what is the likely infection. And most importantly, it is to sending appropriate cultures. So all these patients who are presenting with ACLF, sending timely cultures, blood cultures, good volume blood cultures, ascitic tap, and in ascitic fluid for routine microscopy, as well as for cultures. And in cultures, I would like to add that to increase the yield for cultures, it is important that we inoculate these fluid at bedside in blood culture bottles so that the yield is better. Then urine, urine routine, urine cultures. Then we come to markers of infection. CRP
Right.
may not be a reliable marker in liver disease. Procalcitonin has a moderate efficacy is important, but we have to take it in the clinical context, the markers. So bacterial infection is the most common, but other is the invasive fungal infection is our concerns. So in situations that we are worried about invasive fungal infection, where there are risk factors of invasive fungal infection like Candida, so there are markers that can be used, but we need to judiciously use these markers in liver disease patient because sending beta-D-glucan or galactomannan all the patient is not recommended. So beta-D-glucan we use mainly as it has a good negative predictive value. So if I start an empirical antifungal and a beta-D-glucan is negative, I can tell that there is no fungal infection and I can stop it. But if it is positive, doesn't say. Same using galactomannan, we preferably no, it has to be used in the context where there is a pre-test probability. If somebody has a nodular shadows, no suspicion of because these galactomannan studies are there in neutropenic patients. So there are limited studies for their sensitivity and specificity in cirrhotic or ACLF patients. So we should use them properly and go for, if it is feasible, we try to go for invasive sampling whenever feasible, especially if there are lung infections suspected, quick bronchoscopy and BAL can give a diagnosis very easily, especially when you are using rapid diagnostics now that a lot of rapid diagnostic tests are available like BioFire, BCID panel is available, respiratory BioFire is available. So judicious use of this is also very important so that we identify these infections and then timely treat it.
Correct. So very important to identify infections, and sepsis is the biggest killer. So we have to give the right antibiotics at the right time. As Dr. Wasim said, we use CRP, procalcitonin. The fungal markers in the serum do not have so much of a value because they might be falsely positive. False negative values have more importance. As for galactomannan, we prefer doing the BAL galactomannan if required. So sending out the cultures, blood, urine, doing a chest CT, very important in this group of patients. Because infection then again also becomes a relative contraindication to transplant.
Time's up, ma'am.
So what is your antibiotic protocol in these patients?
So in this patient, it should be a risk stratification based approach. You cannot have a single approach for each patient. So risk stratification will depend upon two things.
So what are the empiric antibiotics do you start with in a patient with shock?
So in shock, I don't want to take chance here because the risk that if I start inappropriate is high. So in a septic shock, when I'm suspecting abdominal source of infection, gram negatives are my major concerns, and if there is a recent exposure, carbapenem to begin with would be my choice, plus minus use of gram positive MRSA enterococcus coverage in case we use vancomycin or teicoplanin, and if there are risk factors for fungal infections, then echinocandin.
Sure. Okay.
So in this case, meropenem and teicoplanin or vancomycin.
Right. So start with a broader antibiotic coverage and then taper as the cultures come in.
Time's up, ma'am. Time's up.
So I think the transplant part will be covered by Dr. Gaurav in his talk. I think let him cover that then. I'll just go to the end slide.
So I'll quickly talk about the transplantation aspect in acute-on-chronic liver failure. We have already seen a lot of aspects of what is acute liver failure and what are the precipitating factors. So it's a big problem in our part of the world. You can see that the highest prevalence of acute-on-chronic liver failure is in Southeast Asia and in India, and a lot of it is because of the incidence of the MDR infections which we all encounter in a day-to-day practice. So this is how a stable cirrhotic usually progresses. If there is any inciting event, then the presentation can be in any of the 6 forms. And what we are worried about is acute-on-chronic liver failure because they have the highest short-term mortality. So 2 basic groups to define ACLF is the APASL, which is the Asia Pacific, and second is the European group, which is the EASL. So there is a basic difference in the whole concept of ACLF in the 2 groups. If you look at the EASL definition, it is any patient who has liver cirrhosis with organ failures. And if you have APASL, it is pure liver failure. So any cirrhotic who develops jaundice, that is a bilirubin of more than 5, with appearance of ascites and coagulopathy within 4 weeks is classified as a ACLF. So the criticism of the APASL group is it underscores patients of ACLF, and that's why the predictive mortality is lower, which is now corrected in the latest Kyoto consensus. So there is a difference in how these 2 groups define ACLF, and that's why a lot of recommendations from the 2 groups will not tally. We are in India right in the middle. We are neither towards the east, we are neither towards the west. We fall right in the center. So we have to mix and match both the recommendations and find out what is suitable for our group of patients, because over the last 10 years, we were a confused lot. When we were following the APASL, we were not getting the optimum outcomes. When we were following EASL, we were not getting optimum outcomes. Over the last 10 years, we have realized what is actually good for our subset of patients. So this we have already covered, that the common precipitants of acute and chronic failure are infections, GI bleed, viruses, and drugs. Now this, I think Dr. Alisha also wanted to show, and this is, I think, the most important take-home message from my presentation. So what we have realized is APASL group, or the patients who have pure liver failure, are the patients who we commonly encounter in our cohort, but which are frequently missed. Now, a patient who has been diagnosed with liver cirrhosis, who suddenly presents with worsening of his jaundice, and then he has ascites, he falls in this definition of acute and chronic liver failure. And the window period which you get is only a period of 7 days. This is the most crucial part of the ACLF, because after 7 days, they get a septic insult. They go into this phase of immunoparalysis, they become septic, and they develop multi-organ failure, and this is the stage when actually the patients cannot be salvaged. So you have a large data of over 10,000 patients from the European Liver Transplant Registry, which showed that patients who have chronic liver disease, once they land up in the ICU, only 20% of them can be salvaged or can be bridged to the stage of transplantation. And most of us will see patients actually, when they present to us, beyond the window period, that is, they have already presented with immune paralysis, they are with sepsis and multi-organ failure. So this is important to know, because this is the time when you should realize when to stop the aggressive management and when you should declare that there is futility of care, because there is no point in just prolonging aggressive management in patients who are not going to benefit from aggressive critical care. And other important thing is of the window period is the urgency to act in these patients. Once you have identified these patients of acute and chronic liver failure, it is very important to correct the precipitating factor and prepare for a transplant urgently, rather than waiting for these patients to get one more insult and then go into multi-organ failure and then referring for a transplant center, because almost all of these patients will not be salvageable. So this is the most important take-home point of this slide of how the natural course of acute and chronic liver failure is. So this Dr. Alisha has shown that why this acute and chronic failure is different from acute decompensation is the higher short-term mortality. Now, acute decompensation in a cirrhotic can be a GI bleed, it can be hepatic encephalopathy, it can be SBP. But acute and chronic liver failure, if you see, the short-term mortality is anywhere between 40 to 80%. That means majority of the patients will not survive beyond a month. So that is why the urgency to optimize them and plan for an early transplant. So clearly, if you see the 2 survival curves, on the red curve is the survival of the patients who have acute and chronic failure and who are managed medically. So there is no survival. You can see that less than 20% of the patients are surviving beyond a month. On the contrary, when you see the green curve, that is a curve for patients who have been transplanted, and almost there is a 80% survival. So you can save 8 out of 10 patients of acute on chronic liver failure if you identify them early and if they have transplanted early. So that is the importance of early identification and optimization. And this is another most important algorithm which has come from the Kyoto consensus. This is again the Asia Pacific group. So how you go about planning patients for medical management or transplant. So there is a very simple score which is called as the R score. And this is how the algorithm goes by. If your R score is less than 10, then you can breathe easy. You can continue the medical management and see how the patient fares. If the R score is worsening or if the R score is more than 11, then you have to act quickly, you have to optimize the patients quickly, and you have to plan for a transplant quickly, because these are the patients who are going into multi-organ failure, and once extrahepatic organ failure sets in, it is very difficult to get these patients back, because the second hit is always sepsis. And most of these patients get more than one second hit. It is not sepsis. Sometimes they get sepsis and a GI bleed and a combination of precipitating events. So it becomes very difficult to get these patients out, and that is the importance of understanding the pathophysiology of acute on chronic liver failure. So who needs a transplant? I think this we all know, decompensated cirrhotic needs a transplant. Almost majority of the transplant which we do are living donor transplants. And this is the MELD score. So MELD of above 14 will need a transplant, liver transplant. If it is more than 20, they need a living donor because of the scarcity of donors in our part of the world. And this is how the transplant discussion is initiated. So what if you don't have a compatible donor? Now, you will face this scenario in almost 20 to 30% of the times when you need an early transplant. If you don't have a compatible donor, then these are the options. ABO incompatible liver transplant from a different blood group, or you can plan a swap transplant. I mean, so if you have a family who doesn't have a compatible donor, then you can identify another family which has an opposite blood group donor, and then the transplant can be planned. And this is the protocol for the ABO incompatible transplant. Now again, mind you, these transplants are only done for patients who have pure liver failure according to the APASL definition. If you have a patient with extrahepatic organ failure like encephalopathy or kidney failure, then you should not plan ABO incompatible transplant. But having said that, if you choose your patients well and if there is no compatible donor, these patients cannot wait on the deceased donor waiting list because of the long waiting period, and then this is a suitable option for transplanting these patients. And this is our own data which we are presenting this year in the national conference of the ABO incompatible liver transplants. Out of the 500 transplants which we have done, almost 35 of them are ABO incompatible liver transplants with identical survival as that of a compatible transplant with 90% 1-year survival. So this is the outcomes of the donor. You can see that the donor recovery of the liver function test happens within a week. By day 7, the bilirubin and INR have touched the baseline. And what we are doing new in these patients is robotic donor hepatotomies or robotic liver transplants. You can see that there is a much lesser incision, minimally invasive, and the recovery is much faster as compared to a conventional transplant. So these are some of the intraoperative views of how a robotic liver transplant is done. So you can see that the magnification is much better, your accuracy is higher, and the tissue trauma is less, and the recovery is much faster. So this is a case of acute liver failure which we were discussing. This is a young girl with massive cerebral edema. She had presented to us with high-grade encephalopathy. What we did differently is not a conventional two lobes. This is the native liver and this is the transplanted liver from the donor. And you can see that the bilirubin and the INR have recovered on day 7. What is different about this transplant is you can see that after 3 to 6 months, once the pathology is reversed of the acute liver failure, the native liver regenerates and grows in size, and you can take the patient off immunosuppression. So this is the biggest advantage of the auxiliary liver transplants in patients who have acute liver failure, because you transplant them as a life-saving measure, but then they can lead a normal life which is devoid of immunosuppression. And this is so far our data in the last 4 years of the transplants which have been performed by our group. So, as you can see, almost 10% of the transplants are deceased donor, 20% are pediatric, and 70% are deceased donor. And the commonest etiology is the fatty liver or MASLD followed by alcoholic liver disease. And this is the data for acute liver failure. In the last 4 years, we have transplanted almost 20 patients with 80% survival, and these have been the commonest etiologies which we have seen: viral hepatitis followed by drugs. And this is the data for transplants in acute-on-chronic liver failure. And this is the recent data which we have analyzed. So again, you can see that this is the transplants which we have done, almost 92 patients for acute-on-chronic liver failure. And you can see that the survival in grade 1 is identical to that of the chronic liver disease patients, which is almost 90%. And in grade 2 and grade 3, it is 80%, which is 10% lesser than patients of chronic liver disease. But this is because the patients are inherently sick and they have multi-organ failure. And we have found that the poor risk factors or when transplant should not be done is any patient who is on inotropic support, any patient who has lung injury and your PF ratio is less than 200, any patient who requires renal replacement. Now this is where we are at crossroads, because a lot of the Western literature says that you can transplant patients with ACLF2 and ACLF3 with equal survival, but this is very different from our own experience in the Indian cohort, because our patients with extrahepatic organ failure don't seem to tolerate transplant as well as the Western cohort. And I think there are two important differences. One is the kind of the MDR infections which we see in our part of the world. And second is the difference in the type of transplant, because most of the transplants which we are doing are living donor liver transplants, and the transplants which are done in the Western world are the deceased donor liver transplants. So they have a better tolerance of recovering from multiple organ failures.
Time's up, sir.
And I think to summarize, early identification is the key in saving or treating patients with acute-on-chronic liver failure. So you should neither transplant them too early if they are responding to medical management, especially patients with alcoholic hepatitis, nor you should be too late in pushing the trigger for transplant. And with advancements in surgery, immunosuppression, the ID protocols, intensive care, the results of transplants in acute liver failure are continuously improving with time. With that, I would like to thank you from all our group. I would like to thank our chairpersons, Dr. Mayank Agrawal and Uday, all our panelists for being here and helping us and participating in this discussion. And also, I would like to thank the Intensive Care Society of Surat for giving us this opportunity to be here and present our experience. Thank you.
Thank you, Team Max Nanavati. Thank you so much.